So welcome everybody to the December IIDR rounds. I'm glad you found us. We had a bit of our webinar seems to have gone up in smoke, which is very unfortunate, but here you are, so it's all good. I'm very happy today to introduce our speakers, Anastasia Chouvalov and Jeff, aka Des Pernica. So Anna is a master's candidate in the medical sciences program as part of the infection and immunity stream. She works with both Don Bowdish and Deb Sloboda in the Department of Pathology and Molecular Medicine. Anna's thesis centers on investigating the impact of the maternal diet during gestation on offspring immune responses to strep pneumo infection. Anna graduated from McMaster in 2015 with a BSc in Life Sciences and did her BSc in Nursing in 2017, a double threat. Her interest in the impact of diet and socioeconomic factors on child health and infection recovery stems from her work as a registered nurse in McMaster Children's Hospital Emergency Department. So welcome, Anna. Our other speaker this morning is Dr. Jeff Pernica. He is an associate professor with McMaster's Department of Pediatrics with main research interests in the diagnosis and management of respiratory and enteric infections in children. He is currently conducting a clinical trial in Botswana investigating whether rapid test and treat algorithms and/or probiotic treatment of children with severe gastroenteritis is associated with improved growth, decreased diarrhea recurrence, and a more healthy intestinal microbiota. He is also running clinical trials in Canada, exploring whether the minimization of antibiotic exposure for children with a community-acquired pneumonia and otitis media is associated with less antimicrobial resistance and less disruption of the intestinal microbiome. Today, he will be discussing new developments related to the diagnosis and treatment of community-acquired pneumonia in children based on 2 recently completed studies. So thank you both, and I believe Anna is going to speak first. So if you would like to share your screen, that would be great.
Okay, thank you so much. So hello everybody. Thank you so much, Lori, for the introduction. My name is Anna. I'm an MSc candidate with the honor of being supervised by both Drs. Don Bowdish and Deborah Sloboda, and today I'd like to take you through the first year of my thesis in the medical sciences program. So in the Bowdish Lab, we are specifically focused on pneumococcal infections, or Streptococcus pneumoniae. And in the Sloboda lab, we focus on maternal diet and obesity during pregnancy. So how do these 2 labs come together? Well, interestingly, both pneumococcal infections and maternal diet during pregnancy can have lasting impacts on health across the lifespan. And that's where I come in. Because my project is to investigate how a maternal high-fat diet may program alterations in offspring immune function in a way that not only affects their responses to Streptococcus pneumoniae, but perhaps actually alters their recovery. Before I was a sleep-deprived graduate student, I was a sleep-deprived nurse. I started my career at McMaster Children's Hospital as a part of the nursing resource team. And so I essentially I floated to all the departments, which means I had the opportunity to work in a number of settings from neonatal ICU to adolescent mental health. I then settled into working in our ED, where I got to see anybody that passed through the hospital doors. And in my time there, I did come to notice that we had a number of repeat visitors, and some children were undoubtedly more susceptible to infection and were in our department multiple times a season with respiratory infections in particular. And I began to question why. So beyond genetic susceptibilities, we all know there are a number of environmental impacts on the trajectory of one's health. Of course, we have the 12 social determinants of health listed here. However, our understanding of the predisposing factors to infection susceptibility, it's now expanding to include the intrauterine environment. Maternal disadvantage is unfortunately and not surprisingly associated with a poor dietary intake during pregnancy. And what may be surprising is how these factors can independently predict immune function in offspring. This presents a compelling case for a causal link between maternal diet and respiratory infections in children. Termed the developmental origins of health and disease, it's been theorized that environmental insults during pregnancy are the early origins of chronic adult disorders. Broadly, in this 2-hit approach, a hostile uterine environment is the first hit. It can essentially be caused by poor nutrition, inflammation, metabolite, or hormonal perturbations, and the fetus responds by developing adaptations to foster its survival if a similar environment is encountered later in life. The second hit of a postnatal exposure can trigger altered responses as a result of the developmental changes, which can confer poor outcomes from challenges that are experienced postnatally. And in this field of study, there's been a rising interest in the effect of the inflammatory environment of human maternal obesity and high-fat diet during pregnancy on offspring health. And this is for a number of reasons. Well, first, 60% of women are presenting as overweight or obese at the time of conception, and as many as 25% are remaining obese throughout pregnancy. Interestingly, a higher maternal BMI has been associated with increased markers of inflammation throughout pregnancy and increased risks of offspring pneumonia and hospitalization for respiratory infections. There's been increasing attention placed on this adverse maternal environment, with particular attention to how the maternal systemic inflammation may act on fetal immune development. Now, if you have investigated the direct mechanism of this maternal inflammation on changes to fetal immunity in the context of respiratory infection. However, there are a number of studies that have looked at these phenomena separately. So in a study that sampled umbilical cord blood from babies born to lean, overweight, or obese mothers, they assessed monocyte populations in the cord blood by using flow cytometry. So it's like a means of cell sorting. And they did this as a measure of systemic inflammation. So when they assessed the frequency and function of these monocytes, the babies born to overweight and obese mothers exhibited significantly decreased TNF production in response to inflammatory receptor stimuli, and that they were actually hypo-responsive to an inflammatory trigger. What's interesting in the human data is that in studies that obtain measures later in life at approximately 12 years of age, children born to obese mothers have now higher levels of another typical marker of inflammation. So this is C-reactive protein in their blood. Now, there may be some evidence to say that the inflammatory uterine environment that is typical of maternal obesity may in some way prime offspring to adapt a hypo-responsiveness to a chronic stimulus that continues into later life. This chronic inflammation has been shown to precede chronic illness and result in poor outcomes from infectious challenges. So perhaps this is the second hit, and it hits at a mechanism by which the children exposed to maternal obesity during pregnancy may also be predisposed to pneumococcal infections and their consequences. Of course, the issue with human data is that our typical markers of inflammation are sourced from blood samples pretty exclusively. We're not typically collecting tissue samples for any evidence of tissue-specific inflammation that may lend susceptibility. But this is possible with animal data. And before I move into the animal studies, I do want to present the caveat that human diets during pregnancy are not only difficult, but also unethical to control. So many human studies are focused on the impact of maternal obesity to really pull this away from the muddy waters of obesity, which can be so metabolically complicated, and to purely assess the impact of diet, you also need these animal studies. And they've given researchers great flexibility and control in manipulating these measures of interest. I'll review some tissue-specific changes that have been studied in these cohorts, and importantly, without the complication of obesity. So in response to a high-fat diet solely, animal studies have shown greater numbers of inflammatory cells, specifically macrophages and neutrophils, within the perivascular, peribronchial, and alveolar septa of the lungs. And in addition, elevated inflammatory cytokine levels, specifically interleukin-6, were observed in lung aspirates. So we've captured changes in frequency of these immune cells and their function in releasing inflammatory markers. Another study demonstrated greater immune cell-mediated lung tissue remodeling. So now we're seeing the consequence of these changes as evidenced by this collagen deposition and fibrosis in maternal high-fat diet offspring compared to controls. Now, this is before any infectious challenge, so one can speculate that this may be a detriment if exposed. And it's also well known that lung inflammation has been shown to potentiate Streptococcus pneumoniae-mediated damage and infection outcomes in mouse models. So again, it's important to mention that these similar inflammatory patterns that I mentioned in the human data have been found in response to just a high-fat diet in the absence of obesity in animal studies, suggesting that this may actually be a root cause of these changes. Taken together, fetal exposure to a maternal high-fat diet could result in changes to offspring immune cell function and a pathological airway remodeling, which may confer altered responsiveness to this challenge. So at this point, I really should address, why are we so interested in pneumococcal infections? Well, as I'm sure many of the ID docs here know, Streptococcus pneumoniae infections are highly prevalent. It's actually responsible for millions of deaths annually and is the leading cause of bacterial pneumonia, meningitis, and sepsis. Streptococcus pneumoniae itself is actually a pathobiont of the upper respiratory tract. And this means that under normal circumstances, it lives as a non-harming microbiota of the upper airways. Despite this, when conditions are altered in the host, it has the potential to invade sterile tissues and cause severe disease. So when it reaches and invades the lungs without any sort of circulatory system involvement, this is labeled as a non-bacteremic pneumonia. And in contrast, when the bacteria is able to breach endothelial barriers and disseminate to sterile tissues, even breaching the blood-brain barrier, and resulting in a meningitis. This then becomes an invasive pneumococcal disease. So while these factors that I've discussed may predispose the offspring to adverse pneumococcal infection outcomes, the mechanisms still remain unclear. In addition, a lot of these factors that I discussed are studied individually and rarely in the holistic model and context of a respiratory infection. So my hypothesis going into the attempt of such an experiment was as follows. We hypothesized that offspring of dams that are fed a high-fat diet will have altered immune responses to Streptococcus pneumoniae infection. And our research questions were broadly, does maternal high-fat diet lead to poor outcomes of the infection? And does a maternal high-fat diet perhaps lead to differences in systemic inflammation or tissue-specific inflammation in those offspring? So in testing this hypothesis, we fed dams either a high-fat or a controlled diet. So we randomly allocated them to the two groups, and we ended up with 20 high-fat diet-fed dams and 11 controlled diet-fed dams. They were on this diet for 2 weeks prior to mating, throughout gestation and lactation. And since we were specifically interested in assessing maternal high-fat diet-related changes to offspring, the dams in our study were not obese. And so we were able to do so by feeding them a diet made up of 45% kilocalories from fat, and then comparing it to a standard chow diet, which is typically 17% kilocalories from fat. And these are pretty standard diets in these types of studies, so it allows us to cross-compare. All offspring were then weaned to the same healthy aging diet. So truly at this point, the only difference between the two groups is the maternal diet, and they were treated the same throughout their lifespan. Though explicit obesity was not notable between groups, we did see that a maternal high-fat diet did elicit differences in gestational weight gain between groups. So the mothers started at about the same weight and were on their respective diets for 2 weeks. And as you can see here, there was a steeper increase in weight gain during gestation in the maternal high-fat diet group. Once they gave birth, they weighed the same again, and the maternal high-fat diet group actually plateaued during lactation, whereas the controls tended to lose some weight with lactation again, to the point where there was a significant difference between groups upon weaning of the offspring. It's also definitely worth noting too that we had some higher measures of adiposity in the high-fat diet-fed dams. After weaning, we sacrificed the dams, and Dr. Ribeiro of the Bowdish Lab did a number of tests on these mothers, and we saw that in measures of mesenteric fat, which is a relatively reliable measure of adiposity in mice, the maternal high-fat diet group had a greater amount of it. I want to emphasize here that though these differences are statistically significant, they are very subtle. These measures were not to the point of qualifying or categorizing the high-fat diet-fed dams as overweight or obese. We did just notice these slight differences between the mothers. The offspring, on the other hand, showed no differences in weight throughout the experiment. And these are measures that Braden Calbro of the Bowdish Lab took from the point of weaning up until the offspring were about 2 months old. And you can see that there is no real difference between groups. In addition, every time we did an experimental measure, we would weigh them again, still no differences in weight. So with the number of dams we had, we ended up with a whopping 119 maternal high-fat diet offspring and 66 controls. And I'm not sure how many of you are familiar with animal work, but I just wanted to say that this age range that we're working with, which is essentially equivalent to like young adults in humans, so about 20 to 30 years of age. So at about 70 days of age, peripheral blood was collected and analyzed by flow cytometry to identify baseline immune cell populations. Then at 90 days of age, offspring were intranasally inoculated with a dose of Streptococcus pneumoniae to induce an acute pneumonia. Ideally, 1 male and 1 female per litter were sacrificed 3 days post-inoculation to assess peak bacterial load and tissue damage. We knew from pilot studies that at about 3 days after the infection or the inoculation, the bacterial loads were the highest, and we did this to see if there were any differences in groups at this acute stage. Those that survived the infection were given a month's rest and sacrificed again with whole blood devoted to repeating baseline immune measures. And then the same tissues were collected as in peak infection dissections to compare to see if there were any long-term changes. So in this preliminary cohort, we chose to obtain blood samples before we infected the mice as a non-lethal means to assess any differences in immune function even before the infection. So essentially any changes that are truly just a product of the maternal diet. In mice, they don't really have CRP or C-reactive protein to the same degree. There are a specific subset of monocytes, however, that are a more sensitive measure, sort of a gold standard measure of systemic inflammation. And these are inflammatory monocytes. And the human equivalents have also been shown to be associated with poor outcomes of infection. So in mice, the major subsets of monocytes are characterized by their expression of the cell surface glycoprotein Ly6C. Again, the proportion and activity of these subsets are a sensitive measure to systemic inflammation, which is why we sought to characterize them in our offspring at baseline. Monocytes that are Ly6E high are responsible for the majority of antimicrobial, phagocytic, and inflammatory action of monocytes in circulation. And these cells are highly capable of transmigration to sites of acute infection and injury. Ly6E high monocytes eventually mature into Ly6E low monocytes, and this subset is responsible for early immune activation, neovascularization, and tissue repair. And they are more likely to differentiate into anti-inflammatory macrophages. So it appears that our offspring of dams that are fed a high-fat diet did have, even at baseline, altered immune cell populations in that they had a lesser proportion of the inflammatory Ly6E high monocytes in circulation, and actually more of the Ly6E low anti-inflammatory type when compared to controls. So we're already seeing differences between these groups. How this would affect survivorship, we would soon find out. So we inoculated, like I said, the animals at about 3 months of age or 90 days. And we, of course, assessed survivorship and collected tissues for mid-infection analysis. And lo and behold, the maternal high-fat diet did not influence survivorship of the infection. This is a Kaplan-Meier survival curve. It may look like both sets of males did poor, but none of these differences were actually significant. But here's where things get interesting, though, because even though technical survivorship was the same, we were seeing some really interesting differences at the tissue level. You'll remember I spoke of Streptococcus pneumonia being the leading cause of meningitis with its unique ability to breach the blood-brain barrier. So of course, we sought to collect the brain tissue for bacterial counts to compare between groups. However, when we opened things up in order to extract the brains, we saw this phenotype. And this was exclusively in the maternal high-fat diet group. We saw these cortical hemorrhages during the acute infection stage. And this was really our first hint of fundamental differences between the groups in their responses to the infection. This is something we didn't expect to see at all, so we quickly decided to devote, a hemisphere from each brain to histological analyses with plans to explore further in the future. Importantly, despite this stark difference between the groups, the bacterial counts in the brains were not statistically significant. So despite the fact that the bacterial load is the same, the immune response may be different at the site such that we see these hemorrhages. Where we did observe differences in bacterial counts was in the lungs. The maternal high-fat diet group actually did have significantly higher bacterial counts in their lungs during peak infection. So even though survivorship is the same, we are seeing these higher bacterial counts in the lungs of the maternal high-fat diet group. And then this is different from other implicated tissues like the brain, where the counts are the same, but we're seeing these stark phenotypic differences. So we did allocate pieces of the same lungs for mRNA and histological analyses, and we're currently working on assessing any differences in immune cell infiltration and infection-mediated damage between groups. And also in the survivors to see if there are any long-term differences, which will hopefully bring us closer to understanding the mechanisms by which the lungs of these mice are able to clear the bacteria to a lesser extent. We did actually collect some of the offspring at 7 days of age as direct postnatal measures. And Brianna Kennelly of the Bowdish Lab analyzed the lungs of these neonate siblings by qPCR analysis. And the maternal high-fat diet group at 7 days of age showed an increased expression in PATH-R, which is a host receptor that is primarily implicated in pneumococcal adhesion to an invasion of cell layers. And we wonder, despite similar survivorship, if these upregulated receptors may be implicated in the higher bacterial counts of the maternal high-fat diet lungs. Again, this is reinforcing our inkling of developmental predisposition to the pneumococcal infection that is already present in this maternal high-fat diet group postnatally at 7 days. This could be that first hit, part of a subset of fundamental differences incurred as a result of the maternal high-fat diet in utero that changes their responses to infection postnatally. In addition, we also did take some measures of immune function in the animals that survived the infection. So we isolated samples of monocytes and stimulated them with an inflammatory trigger, and we were able to see how much TNF, so how much of an inflammatory response these cells were able to produce. So this is less of a measure of differential frequency of monocytes between groups and more actually how these cells function in response to a stimulus. What we found was that both the inflammatory and anti-inflammatory monocytes of the maternal high-fat diet group had less TNF production when stimulated, and that generally they may have been hypoinflammatory compared to controls, which, as you may remember, is reminiscent of the cited study I spoke of earlier with the babies being born to obese mothers also having blunted responses to stimulation. So at this point, it's clear that the maternal diet is predisposing these offspring to respond to the bacteria in different ways. It appears that these offspring are fundamentally different in the way that they handle the infection, and this changes tissue to tissue, as we saw in the lungs and the brains, which, let's not forget, are major sites of damage for this bacterium. And even though survivorship is the same, the differences in immune activation that we see across tissues may be tied to lasting impacts even after infection recovery. Because pneumonia isn't just an acute infection, there are some major long-term consequences of the disease. In humans, those who survive the infection, they're at an increased risk of acquiring a number of non-communicable diseases that impact not only their life expectancy, but the number of years they spend in good health. These individuals have a greater chance of developing cardiovascular disease, metabolic disorders, and dementia. Consequently, pneumococcal pneumonia has been listed by the Ontario Burden of Infectious Disease Study to carry the largest financial burden of any bacterial infections when considering years of life lost, healthcare costs, and health-adjusted life years. And I mean, this helps me better understand what I was seeing as a nurse, because even in children, having had pneumonia in the past increases your risk of acquiring the infection yet again in the future. And with such consequences of the infection, these children are heading down a path of susceptibility to chronic disease. We were actually able to catch a whiff of this in our study too. There are a number of studies that show pneumococcal infections have an impact on muscle wasting and deconditioning as measured by grip strength. So in our preliminary cohort, we were able to recapitulate these post-pneumonia sequelae to a degree, and it wasn't too long after the infection had resolved. So remember, we allowed about a month's rest after the infection. And at that time, we did a version of grip strength testing in the survivors of our infection model. You place them on a grate and you flip it over, see how long they're able to hold on until they fall into a soft bed. And we found that the maternal high-fat diet group fell more readily, sooner, essentially. Again, they weighed the same as cohorts, so this wasn't a measure of gravitational pull. This is not an exhaustive assessment, but it's an interesting measure that we plan to explore further. And we also did see some behavioral differences in groups, and that coupled with what we were seeing in the brains has us really looking forward to our next cohort. So just to briefly walk you through, we are doing this again in January. Some of the key differences I wanted to point out with this next group is there will be significantly more pre-infection measures. We'll collect tissues from a subset of animals as well, just before the infection. So there's sort of an age match control, and we plan to look more closely at their lung immune cells and their cytokine production to see if there are any baseline differences there at the tissue level. We'll also likely be collecting brain tissue for testing beyond histology and bacterial counts. And we'll add a rigmarole of validated behavioral and strength testing to explore further what we saw in our preliminary cohort. So to our knowledge, this is the first study that may function as a model of assessing developmentally programmed vulnerability to post-pneumonia sequelae. We believe that a maternal high-fat diet may predispose offspring to tissue-specific immune changes that may confer poor long-term impacts of the infection itself. And with that, I'd like to thank the IIDR and the Lung Health Foundation for funding this exciting project. And most definitely my team in both labs. It's been an enormous effort that's essentially involved everybody pictured here. So big thank yous to everybody. Thank you.
Thank you so much, Anna. That was a fabulous talk. We're going to save the questions to the end. So if you have questions for Anna, please type them in the chat, and then we'll deal with them after Dr. Pernica's talk. Thank you, Anna.
So I'm going to be talking about community-acquired pneumonia in kids. And this talk is going to be a little bit different than Anna's, because that was amazing. And the degree to which little at all. This is not working. Oh, here we go. So as Anna's already talked about, community-acquired pneumonia is important because it's a leading cause of antibiotics for kids and emerge visits for kids and hospitalizations for kids. So you'd think, okay, that we know a lot about it. And as we've just seen, scientists know a lot about Streptococcus pneumonia infections in mice, but there's a lot of things that we don't know about humans, like how to diagnose pneumonia reliably, or what causes it in an individual kid, or really how to best treat it. So if we look at the etiology or the microbiologic causes of community-acquired pneumonia. Now, classic teaching is it's caused by bacteria, and as Anna's already said, we would all agree that strep pneumonia is the most important cause. Now, spoiler alert, in kids, there was a lot of pneumonia that's caused by non-bacterial pathogens. And this was demonstrated very well by this seminal study that I bring up all the time, which was a multi-year, multi-center study in the United States where they tried to capture every kid admitted with community-acquired pneumonia to 3 major hospitals. And they really described them thoroughly. Now, just to put it out there, these kids did not have mild disease. So they were all admitted to hospital. And as you can see here, 1/5 of them were admitted to the ICU. And this is what they found in terms of microbiologic causes of pneumonia. The blue here is virus, either one virus or multiple viruses. And though the proportion of viral disease is smaller in the teenagers, there's still tons of viral infections in everybody. This color here, okay, is bacteria only. Here it's bacterial viral. And you can see that the numbers are really quite smaller. Here it is broken down by specific respiratory pathogen. Unsurprisingly, RSV is at the front, which is because it is probably the most important respiratory pathogen in all age groups. There's a lot of rhino, which we're not going to talk about today. And down here is strep pneumo in about 4% of participants. Now, this definitely undercalls the importance of pneumo, okay? And you see graphs like this because our diagnostics for respiratory viral pathogens are very good, and our strep pneumo diagnostics in humans are terrible. So this is really blood cultures positive, pleural fluid cultures positive, and some blood PCRs. But still, more than just strep pneumo. And in fact, mycoplasma is here. Mycoplasma was traditionally thought to be, a cause of mild illness, but you find it almost twice as much as strep pneumo in this cohort that was admitted to hospital and the ICU. And so the question is, really, how important is mycoplasma? Classic teaching, it causes sort of mild disease with a prolonged prodrome with diffuse bilateral infiltrates, and you can tell what it is easily. Spoiler alert, none of that's true. So the question that we had at MAC is, how often can you find it in kids with critical illness? So not just admitted to hospital, but in intensive care. We took every admission to the MAC ICU over a 13-month period, and this is the microbiology that we found. So down here is strep pneumo. Again, our strep pneumo diagnostics are no good. Okay, we only found 1 in the 227. We found a couple of group A streps and pleural fluid. We found tons of RSV, unsurprisingly. And here's some mycoplasmas. So not tons, only 10, but it's certainly more than strep pneumo and group A strep, which is what we tend to worry about from a clinical treatment standpoint. Now, the other thing that we found, okay, that has been found in just about every cohort that has been examined is that the incidence of mycoplasma increases with age until young adulthood. So if you just look at the school-aged kids, we could find mycoplasma in 13% of them, okay, who had pneumonia in the intensive care unit. And so really, I think rapid testing should be considered in these treatment because it's entirely possible that targeted therapy, which is not the standard of care, could improve outcomes in these sickest of kids. So let's move to how pneumonia is diagnosed. And I should say that it's not really easy to recognize, although often parents will think that it is and get mad because the previous doctor said that their kid did or did not have pneumonia. So in humans, okay, pneumonia often presents with fever, rapid breathing, difficulty breathing, and levels. Bronchiolitis, okay, which is a viral disease, can also present with all these things. And exacerbations of asthma, most commonly from viral intercurrent infections, can be the exact same too. So what do we do about this here? Now, the thing about pneumonia is that you really shouldn't see wheeze, and you often see wheeze with either bronchiolitis or asthma. So that, I think, is a very useful clue, but it's not perfect, right? You may not hear wheeze in kids with bronchiolitis. And in pneumonia, if you do have a viral superinfection, you could conceivably have some wheeze. If you do an X-ray, you should see parenchymal infiltrates on with pneumonia. Whereas with bronchiolitis, you should not see these. This is complicated by the fact that it is very clear that if you clinically diagnose somebody with bronchiolitis, you should not do an X-ray. So they are actively recommended against. And there is a substantial degree of variability on frontline providers' ability to interpret chest radiographs. Now, as we've talked about, pneumonia can be caused by a multiplicity of pathogens, whereas bronchiolitis is viral, and asthma is usually triggered by viral infections. Now, the reason it's important to make this distinction, obviously, is because there's a bunch of kids with pneumonia who we would treat with antibiotics. And categorically, antibiotics should not be given to kids with bronchiolitis or asthma exacerbations by viral intercurrent infections. Now, some have recommended measuring the quantity of Streptococcus pneumoniae in the nasopharynx to diagnose pneumonia. And I would have thought that this was a bad idea based on what Anna's already said. Like, we know that pneumococcus is a colonizer of the sinopulmonary tract, right? So how useful can it be? But if you can see, the journals in which these articles were published are very high impact journals, right? And so we figured, why don't we look at that to see if it's actually useful in our populations in the Canadian sort of post pneumococcal conjugate vaccine era. And so we took those kids from the ICU that I've already mentioned. We took another 122 kids from the pediatric inpatient ward who were admitted with respiratory disease. And we took 179 kids who were diagnosed with acute pneumonia in the emergency, all of whom had an MPS that Kathy and Merrick did PCR on to quantify their pneumococcal loads. And we divided them into disease categories, things that were obviously viral, so bronchiolitis, things that were obviously bacterial, like pneumonia with a big bunch of pus around your lung. And then the ones in the middle, the regular pneumonias, the ones that it is very difficult to tell who's got a virus and who's got a bacterium without a percutaneous lung biopsy, which, needless to say, parents aren't super keen on most of the time. And this is what we found. So here are the disease categories at the top, the viral syndromes, the bacterial syndromes, and I split the sort of indeterminate pneumonias into the non-severe, so the emerge ones, and the severe, so the inpatient ones. There's clear differences in the ages of the participants in each one of these categories. So there's much more little kids in the viral syndrome than in the bacterial syndromes. But if you look at the ones who don't have any pneumococcus detected, it's very similar among the categories, except for whatever reason, the ones in the emerge. And then in those who are positive, the distributions of the pneumococcal genomic loads are essentially the same. And so what this means at the end of the day is that once you adjust for the age of the child and the place where they're recruited, whether it's the ICU or the emerge of the ward, there is no difference, okay, in the percent positivity, the genomic load, or the proportion that are colonized between kids who have clearly viral syndromes, bacterial syndromes, and the ones in the middle. And so this really shouldn't be used as a diagnostic test. This is currently under review. So let's talk finally about treatment of pneumonia in children. And it's really not clear. So the guidelines say 10 days, even for kids who don't need to be admitted to hospital, but it's clearly recognized that this is really based on nothing. And we know, because it's much easier to to get people to do studies on themselves rather than on their kids, okay, there are high quality randomized trials that have been done that clearly show that adults with either non-severe disease or severe disease do just as well with 5 days of antibiotics as compared to 10 days of antibiotics. And so we asked this question. So for kids who are diagnosed with pneumonia in the emerge, does 5 days work as well as 10? We did it at both McMaster and the busiest pediatric emerge in Canada, the one in Ottawa, in a randomized, blinded fashion, randomizing these children aged 6 months to 10 years to either amoxicillin 5 days or 10 days with a placebo in there to preserve blinding. Now, the outcome, we want to know who was cured. And so, I think we all think we know what that means. It's hard sometimes to write it down. And so this is what we came up with. They had to get better over the first 4 days. And then when they came back for had any extra antibiotics or be hospitalized for infection. Later on, for reasons that I'll show you about, we thought, that is a little bit too strict. Maybe we'll just say, we'll use modified clinical cure and say, look at who got better in the first few days and who didn't have anything bad happen to them. So who didn't get hospitalized and who didn't need extra antibiotics. We also looked at some other things that we thought would be important to kids, their caregivers, and clinicians. And so over the years of the study, we randomized to either one of these two arms. We lost about 11%. Thankfully, at enrollment, those randomized to 5 days were similar to those that were randomized to 10 days. These are mostly preschool kids, a bunch of them, so anywhere between 24 and 30% did not have pneumonia reported by the radiologist. And that's weird. I have just lost my slides, but nothing else. Can you guys see my slides?
Nope. Oh, there it is.
Yeah?
Yep.
Interesting. All right. Oh, for crying out loud. Is this a joke?
It's 2020, man.
All right, let's try it this way. I'm going to stop using my webcam and move in my apartment. How about now? Can you see now?
Nope.
Okay, how about now?
Yeah, we're on presenter view though.
How do I do? How about now?
Bingo.
Awesome. At the end of the day, this is what we found. So you can see here that the cure rate in those who got 5 days of antibiotics was about 86%. The cure rate in those who got 10 days of antibiotics was 84%, for a risk difference of 2%, which is pretty good, because there's no way that 5 days of antibiotics is going to be better than 10 days. We were just hoping for it to be the same. This 97.5% one-sided confidence interval is sort of the statistical worst case scenario based on the results that we got. And the statistical worst case scenario was that short course therapy was 6.1% worse, which was less than the preset non-inferiority margin of 7.5%. Okay, so by the intention to treat analysis, 5 days of antibiotics was officially non-inferior. Now, there's no way, this 15% failure rate is way too much because kids do well. And a lot of these failures, okay, were kids who got fevers from other things, and so that we couldn't prove, but looked fine and failed, or who got, other viral infections, and so were tachypnic at the primary outcome visit. And so when you look at this modified clinical cure, okay, you get cure rates much more close to what I would expect from my anecdotal experience. And again, the risk difference favors short course therapy, with the statistical worst case scenario being not bad. Now, in a non-inferiority trial, you always have to do the per protocol analysis for reasons that we don't need to get into now. And so by that way, clinical cure was found in 89% of those receiving 5 days and 91% of those receiving 10 days. So in this analysis, short course therapy was slightly worse, with the statistical worst case scenario being 8.7% worse, okay, which exceeded the preset non-inferiority margin. If you look at a sort of better clinical cure outcome, modified clinical cure, cure rates were essentially the same. And the risk difference is good. The margins the confidence intervals are greater here because we lose people in the per protocol analysis. And then if you looked at strict per protocol, so kids who fulfilled the per protocol criteria and who had a radiologist confirmed pneumonia on X-ray, the cure rates are essentially identical in both arms, with the confidence intervals being again wider because you lose about 40% of the cohort in this analysis. Secondary outcomes, for some reason that I cannot explain, and it may not be true, okay, there was 25% less caregiver absenteeism in the children that were randomized to the short course arm. The rest of the secondary outcomes favored short course therapy, but not to a statistical degree. So in terms of kids who miss school, adverse reactions, and adherence to study medications. At the end of the day, what I feel that we can say with some certitude, okay, is that short course therapy is just as good because the cure rates were all comparable, even though they were not formally non-inferior for the primary outcome in the primary analysis. And this has just been accepted within the past month or so to JAMA Pediatrics. But doing this trial, besides being a pain in my ass, it really makes you think that we're asking the wrong question. And really, I want to know, how short can we go? Now, a previous similar trial in Israel stopped a 3-day arm because they had too many failures, but they weren't thinking about it the right way. And I wasn't thinking about it the right way either. So this is what we know. Almost everybody diagnosed with pneumonia in our emerge gets antibiotics, which is usually amoxicillin. Now in North America, or I should say the United States, it's maybe not as high as 98%. It's still 80%, but it's still the vast majority of kids. And we know a lot of disease won't respond to any amount of amoxicillin. So all the viral disease, all the mycoplasma disease. And this huge proportion of kids diagnosed with pneumonia have normal chest x-rays. So how can we do this better? You wish there's other diagnostic tests. We look at serum C-reactive protein, and Anna alluded to this. It can discriminate between groups of children with viral bacterial disease, but at an individual level is not sensitive or specific enough to really make a difference on its own. Urinary pneumococcal antigen in older adults is somewhat useful. Now, it was previously thought to be horrible in kids because it was positive in everybody. But in a recent small cohort that we have at MAC, it was actually insensitive, but relatively specific. So it was only positive in people that we thought had a high probability of bacterial disease. And so the better trial, the next trial is coming. It's going to have this fancy name. I did not come up with it. I think Mark came up with it, actually. And it's going to be a prospective before-after study to see if we can stratify patients with community-acquired pneumonia into low-risk or appreciable risk categories. You know, doing something like this, figuring out, do they have a large pneumonia? You know, and using CRP and a couple of easily determined clinical indicators to decide if they need antibiotics that day. And the next day, we then see, for everybody who doesn't get antibiotics, and this will be a fair proportion, you know, if their NPS just has a virus in it, then we reassure the parents as long as nothing bad happens. Anybody who has a normal chest X-ray doesn't get any antibiotics. If you have something on your X-ray and you have a pneumococcal urinary antigen positive, we call in antibiotics. And then if your NPS is positive for mycoplasma, because there is a non-negligible proportion of kids who will have this, we will give azithromycin, okay, at day 2 or 3 if symptoms do not go away, and sooner if they worsen. Finally, okay, if they look like pneumonia, but they have an NPS that's negative for viruses, given the sensitivity of this test, okay, if they don't improve, obviously they will be reassessed and they emerge. And I think using this strategy, we'll be able to dramatically improve the way that we manage kids with pneumonia. My take homes, we really need better strategies to enable clinicians to diagnose pneumonia. We need better methods to identify the etiology of pneumonia in individual patients, and we really need to improve prescribing.
Thank you so much. That was fantastic. I have a lot of questions myself, but I'm going to first go to the chat. So the first question is for Anna. Fantastic presentation, Anna. I am really interested in what is going on directly in the lungs and the immune responses there. Do you think you may do flow or cytokine analysis after infection in the lungs? And have you thought about testing susceptibility to secondary infections in the survivors?
Yes, so with the second cohort, we decided that we're going to collect a subset of animals even before they're infected and sack them and look at what's going on in their lungs even before they're infected to look at some baseline differences. And in those animals, we'll be doing bronchoalveolar lavage, and we will look at just cellular proportions, and also we'll do some cytokine analyses using ELISA of the bowel fluid. And then depending on what we see there, we will potentially throw in some lung flow in the post-infection animals. So we always had planned to do baseline and post-infection flow in the survivors, and ideally if it's matched. I did do that in the first cohort and kind of checked to see if it correlated with survivorship. So we plan to do that, and maybe we can then compare that to what we see in the BALF and the pre-infection animals, or just compare between groups at the end post-infection. But yeah, depending on what we see in the BALF pre-infection, we will potentially add either flow or BALF again in post-infection, and then always correlating with or coupling, I guess, with blood flow. Yeah, that is the plan. And as for doing a secondary infection, that is a really interesting thought. I think something I had always thought about was what it would be like if we age them for longer, had a second cohort where we aged them into, older adulthood, or where they're aged and then infected them. And maybe some of the mechanisms that either not necessarily confer poorer survival or better survival, but whatever is happening at the state where they're young adults may have these predispositions to a chronic issue later that would confer poorer survivorship later. So that would be really interesting. Yeah, that's a good question.
Yeah, I mean the lung pathology, or the bacterial loads in the lung that you got were surprisingly high, and I know you can have sort of walking pneumonia as a human, and it made me wonder whether survival is not really the right outcome measure for that kind of thing, right? So, I realize strep pneumo is dangerous for a subset of people who get it, but really I guess maybe COVID has made me think about this, right? Permanent lung damage and what that means for your quality of life, not just your lifespan, right?
Yeah, exactly. And I mean, honestly, when we first calculated the survivorship, I was disappointed. I had expected to see these poor outcomes, but then, thanks to my committee, I was we sort of worked through it, and we started to redirect the thought to, yes, the idea of these post-pneumonia sequelae really being the public health threat and these long-term damages. Yeah, absolutely.
Mm-hmm. All right, I have a question for Des. The low colonization rates that you saw with strep pneumo, how many people or children have strep pneumo just in general without any consequences? Do you guys know what the colonization rate is?
So if you mean what proportion of healthy children will have strep pneumo in their nasopharyngeals, I don't know that number off the top of my head. It's going to be a lot, right?
I think it's
And,
like 20% or something.
well,
So it's a large proportion.
I think I bet so previously, okay, in the pre-pneumococcal conjugate vaccine era, right? I bet you it was way higher. Like the reason that you could never use pneumococcal urinary antigen testing was because positivity rates were like 80%. And so it didn't discriminate at all. Pneumococcal conjugate vaccine didn't eliminate nasopharyngeal colonization. It worked very well against vaccine serotypes, but you see a lot of serotype replacement. And that's not bad necessarily, because what you don't want is really the strains that are more likely to cause invasive or severe disease, such as 19A that we had a problem with, as recently as 10 years ago. But it's going to be a large chunk, right? And so I don't understand how this kind of test will ever be able to be used at an individual level, much less for groups of kids. The places where they've used it, there was a huge pneumonia study called PERCH, and it was in resource limited context. So there was a lot of countries in Africa and Asia that participated. That's the CID paper that I showed. And so maybe it's just because definitions of pneumonia there are going to be different than definitions here.
And I have to say, I'm shocked that 98% of kids are given amoxicillin without a diagnosis of a bacterial infection. That blew my mind.
Well, it's because they're diagnosed with pneumonia, right? And so classic teaching is pneumonia is bacterial. Like this is just something that people know. It's not that high in non-selected settings. So that's our pediatric emerge. The pediatric emerge in Ottawa is no different, right? And so pediatricians have lower tolerance, I think, for failures. If you look at the United States, it's more like 75 to 80%, but that's still most. It's because there isn't a diagnostic. Like our human diagnostics are terrible without percutaneous lung biopsies.
That's I was trying to reconcile that with all the efforts that have been made in stewardship in recent years, and it seems like that is, people will still default to just in case. I mean, maybe when it comes to kids especially, right?
Well, because it's amazing. I think it's all provider psychology. And there was a kid that I bring up all the time. We used to think that viral testing would mean that you didn't need antibiotics. Of course, we know now that co-infections are super common. And there was a case, around 7 or 8 years ago, where there was a preschool kid who had pneumonia but looked okay, and their NPS was positive for RSV on a rapid test. So the community provider sent them home without antibiotics, which I think is totally defensible. Then the kid came back 2 days later with group A strep, purpura fulminans, septic shock, died. And that kind of thing stays with a person for a very long time. So even though that's going to provide more harm than benefit in the majority of kids, everybody is terrified of that. Could it be what if kind of scenario? Well,
hopefully the push to rapid diagnostics for COVID will spill over into some of these other diseases, right? Once people realize that you can do this in warp speed, not to give Trump any credit, but I think that it's gonna make some big improvements in how we diagnose infectious diseases. I'm not seeing any questions in the chat, and it's 9 o'clock, so I think I will call it a day, and thank you both again for 2 fantastic talks. I really enjoyed it. And I will see you in the new year. Hopefully 2021 will be a little bit better. The next rounds is January 6th. Thanks and take care.